Hi guys, so welcome back to another Stat Dose podcast, and we're doing another turbo dose. Today we're doing asthma, and we're going to go through an overview in pathology, talk about some features and the assessment and management so that when you go into your simulation and go into clinical practice, you're a little bit more prepared. Matt, I'm going to get you to do the pathology because then people will hate you and not me. So tell me about the pathology surrounding asthma.
Thanks, Joe. It's very kind of you to give me all the good stuff. Asthma is characterised by three sort of things, really. So you get bronchial hypersensitivity, you get inflammation and constriction. This essentially leads to the recurring symptoms of airway obstruction. Now, one of the key considerations with asthma is that the airway inflammation is reversible, and there's often a strong family history of atopy being asthma, eczema, and hay fever. And there are often lots of triggers that will set off some of this bronchial constriction, that being sort of air pollution, smoking, certain allergens like dust mites and things. The cold weather and exercise are two important considerations as well. In terms of the pathology in acute asthma, there's a few important considerations that we're just going to go over. So because of the bronchoconstriction, you get a prolonged expiratory phase, which most of our students are aware of, and this leads to a high airways pressure. Now, the problem here with when you get the prolonged expiration and the prolonged constriction, you can get essentially the concept of breath stacking, where air can enter but not escape because it takes so long for the patient to expire. So you haven't fully expired and then you have to take a breath in on top of that. And that's known as breath stacking. And the issue here is that causes the intrathoracic pressure to rise even further. And this essentially leads to the complications of acute asthma, which informs the grading of asthma, which we'll go on to mention a bit later on. Essentially, as the intrathoracic pressure rises, you can get compression of the great vessels, which decreases venous return. You can get pneumothoraces because of this high intrathoracic pressure as well. And that just leads to further complications. So in acute asthma, that's the key thing to be aware of, that bronchoconstriction causing increasing pressure, causing breath stacking, causing rising intrathoracic pressure.
These patients, when they present to you, particularly from an acute perspective, you're going to be looking at shortness of breath, difficulty in breathing. You're going to be talking about cough, wheezing particularly, and a lot of asthmatics present with this chest pain, but actually often they will describe it as chest tightness, and they will describe that sensation as the normal pain that they get alongside their asthma. Assessment, Matt, of asthma and the acute exacerbation of asthma, how do you go about that?
ABCDE, again, as ever, as you mentioned, feel free to check out our approach to the breathless patient, which will go into that in a bit more detail. But essentially, you want high flow oxygen, you want to consider things like nebulizers and things like that. And as you've finished your A2E assessment, or as you're working alongside it, you want to get some key features from the history. So these include normal medication. Are they compliant with their medication? Their steroid use. Are they on inhaled steroids? Are they on oral steroids? It's uncommon in asthma, does occur. Previous admissions. So how often are they admitted? How many exacerbations do they have a year? Have they ever required intensive care? Have they ever required intubation? Things like that. And if they had this year's flu jab. And the key differentials that you want to try and exclude through your A2E assessment, through your history and examination, is there a pneumothorax, and is there any evidence of anaphylaxis? Because obviously the treatment for both of those are different to asthma. But then really you want to move on and think about grading the severity of the asthma. Now, we won't go into this in full detail, but if you're watching the YouTubes, we'll pop a table up so you can see the grading as per the BTS guidelines. If you're having listened to the audio files, have a look at the BTS guidelines at your leisure. I think probably it's useful to highlight the severe features. So if the patient is unable to complete full sentences in one breath, if their heart rate's above 110, if their respiratory rate is above 25, those are features in keeping with acute severe asthma. I think remembering those severe features should just trigger in your head, this is an unwell patient that you need to be assessing and managing appropriately.
Yeah, I think that's really important because it allows you to understand the severity from the get-go once you've got essentially your initial primary survey. But it's also really important in terms of when you're aspiring over to another clinician, you're escalating that care. If you're able to put a severity to it, like severe, life-threatening, near fatal, then that gives the handover a little bit more urgency, and it's a universal language that's utilised between clinicians, and so it allows you to very quickly hand over the patient and why you're sort of escalating that care. So really, really important. So thinking about the management, then we're clearly going to adopt an ABCDE approach. Hopefully, from an airway perspective, your patient is going to be sort of alert and orientated and therefore not requiring airway support. There are the occasional life-threatening near fatal asthmas that do require airway management, and that would need escalating to senior clinicians as soon as possible, just based on the previous pathology Matt was talking about in terms of high intrathoracic pressures, making it very difficult to manage airway and manage ventilation. Patients are going to benefit clearly from oxygenation, so trying to get that oxygen to between 94 and 98%. And after confirmation of expiratory wheeze, need things like sympathomimetics, so salbutamol as a beta-2 agonist. You can try inhalers for mild to moderate, but usually people go to nebulizers off the get-go if you're assessing an acute episode. And quite often patients will come in having already sort of maxed out their inhaler use, so it's just important to have a think about here. The evidence, which is sort of relatively newer evidence, and therefore practice is a little bit slower in transitioning here, but it suggests that actually, as opposed to back-to-back nebulizations, there's actually little benefit of more than 10 milligrams of salbutamol per hour. And actually what you're going to get instead of any benefit is just an increase in side effects, which can be quite prominent in your nebulizer. Depending on the severity, you can start with 5 milligrams of salbutamol and actually add in an ipratropium, so your anticholinergic. That effects usually last about 4 hours, so it doesn't need to be back to back either. And you're usually given about 500 micrograms of that in an adult patient.
So steroids are important. Just be aware that they're going to take a couple of hours before they have any real effect. But either oral steroids, if the patient's able to swallow, so that 40 or 50 milligrams of prednisolone is normally what we go for, or some hydrocortisone, 100 milligrams IV if they can't swallow, as I mentioned. But magnesium is often one of our go-tos for our more severe patients. If they're not responding to the nebulizers and the steroids that we've given them, then we need to consider magnesium early. We often advocate in SIM that if you're going to start magnesium, you should have at least discussed the patient with a senior colleague. That's not to say that that F1s can't start magnesium. It's just that if you are starting magnesium, that implies it's in acute severe asthma or worse, and so somebody senior should be aware. So we normally give 2 milligrams of magnesium over about a 20-minute period. Generally works quite well, even though the bronchodilator effects are quite mild. And the Australians and the Americans give much higher doses. They give sort of 4.5 or 9 grams. We're seen as relatively cautious in the UK by giving 2 grams. So antibiotics, again, is something to consider. Most exacerbations of asthma are non-infective or viral. So you need to have a reasonably sort of strong index of suspicion that this is a pneumonia on top. So are they coughing up sort of productive sputum? Are they particularly pyrexial? Is there evidence on a chest x-ray, for example? But generally, most of our acute severe asthmas don't tend to get antibiotics. Investigations-wise, just quickly moving on to that then. So we just use sort of a routine blood test, so full blood count using ECRP. Nothing particularly exciting. Consider cultures if you think this is a sepsis. A chest x-ray is helpful, so that'll help exclude a pneumothorax and help exclude a pneumonia if you're worried about those sort of things. ECGs are important because it's good to get a baseline. Lots of salbutamol can cause hypokalemia as it drives potassium intracellularly, so just be aware of that. You might get some hypokalemic type changes in some of the more severe asthmatic patients. So a venous blood gas, not always particularly helpful. If you've got somebody who's got severe asthma or somebody who is hypoxic on air, then they're going to require an arterial blood gas. Refer back to the BTS severity guidelines, and that just makes sense why, but you need to know what the CO2 is doing.
So that's just a quick roundup of the assessment and management of asthma. We've talked about the overview and the pathology, which again is really important in allowing you to understand the assessment and management of this presentation, where we can get high airway pressures from your bronchoconstriction, you can get breath stacking or air trapping, and increased intrathoracic pressures. From the assessment perspective of things, talked about the BTS guidelines, really important, and please do go and have a look at those in order to prioritise your management and give you a universal language with which to hand over. And from a management perspective, we've talked about oxygen, salbutamol, ipratropium, steroids, escalating to magnesium, and then some of the other things that you want to consider alongside that in terms of investigations such as bloods, chest x-ray, ECG. Hopefully this will help you in your clinical practice and or when you're coming into simulation.